Welcome to our monthly webinar on occupational health trends beyond COVID-19. This is Karen O'Hara. I'm the Director of Marketing and Communications at WorkCare and your host for today. Those of you who are joining us for the first time, welcome. Many of you have probably been attending since we started this series way back in March 2020 at the beginning of the pandemic. We've transitioned it to some broader topics, but we still will be also reviewing COVID trends as well as innovations and other activities going on in the occupational health world. This session is being recorded. During the webinar, you will be on mute. Please submit your questions using the Q&A function in Zoom. The webinar recording will be posted on our YouTube channel, and a transcript of the Q&A segment will be posted on our website within the next few days. We'll share the links to those two resources via the chat function during the session. We have a full hour scheduled for the webinar, and we allow time for your questions. So please make sure you get them to us, and we'll get through them as quickly as we can at the conclusion of the formal remarks. And I just wanted to let everyone know we have a special webinar coming up on April 20th on ergonomics and total worker health for industrial athletes. And the presenter for that session will be Brian Reich, who's the director of our industrial athlete program. So you'll be hearing more about that in the next couple of days. If you're on our mailing list for email, you'll get a notice. And if you don't think you're on our list, then please send your email to communications@workcare.com. Now I want to introduce our speaker. You're all familiar with him. Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine. He's a WorkCare consulting medical director. And now I'll turn it over to him. Thank you for joining us. Dr. Harris?
Excellent. Thank you, Karen, and thanks everyone for joining us once again. We would love to take the opportunity today to continue the work that we started way back when, right? In regards to sharing what the top topics of today should be amongst the EHS professionals in regards to protecting the workforce. And we're still, as Karen has mentioned, we'll be touching on COVID here, right? We have touched on a number of things that are impacted by COVID, no different today. So with that, we'll jump into the program for today. And if you are joining us for the first time, or if you're joining us and you missed us for last month, we changed the format a bit. It's reminiscent of how we started 2 years ago. Clinical update comes first, followed by pathology, epidemiology, workforce strategies. And digging into each one of them, we're going to present the clinical presentation that's germane today for your workforce in regards to health protection. Then we'll dig into a deep dive of what's the pathology driving that particular phenomenon. And again, the goal of that is not to make everyone a clinical pathologist, right? The goal is to be able to answer questions as it pertains to you answering questions from your workforce, right? We want to make sure that we're educating our workforce around how to protect themselves and others. Then we'll jump into understanding what the numbers look like. We'll usually, as usual, we'll touch on some of the global numbers from an epi standpoint of COVID, but specifically we're going to dig into epidemiology of the issue that we're here to talk about. I'm saving that as a little surprise here today for you. And then finally, we'll talk about how it impacts the workforce and some strategies to help minimize the risk for your workforce from a protection standpoint. So without further ado, I will mention today, we'll probably end a little early in terms of the formal presentation. I recognize that at this point in time, there's a lot of questions around what we should be focused in on in regards to strategy as a means of a drawdown to some of the activities that we've been doing regarding protecting the workforce. We're looking at the numbers in the US and abroad. Obviously, there's a big difference there. We'll touch on that in the EPI, but I want to save time for questions because I know you all might have quite a bit of them that we can dig into specifics on. So we will save a chunk of time, maybe even 15, 20 minutes at the end, hopefully here to answer those questions in depth. So we want to talk about COVID and diabetes. All right, I know your mind is already spinning. What in the world does diabetes have to do with the setting of COVID, right? And some of you may know the impact that COVID has on diabetic individuals, and surely we'll talk a little bit about that. But what we want to specifically address is what you may have been seeing recently in the news, which is COVID-19 infections increase your risk for developing new onset diabetes, right? Mind blowing, right? This is not something we've presented on before. This is more recent data. Some of the data goes back as far as 2021, but yet and still, we have more data now to suggest that infections of COVID can lead to increased risk for developing diabetes. And so we want to expound on that clinically here, right? What type of diabetes are we talking about? We're actually talking about type 1 diabetes. If you're not familiar with the two different types, let's touch on that briefly so we're all on the same page around the clinical presentation here. So type 1 diabetes is a condition where you're not making insulin, okay? Insulin is what you need to help keep the sugar that circulates in your blood after you eat going to its proper place, i.e. the muscles, fat tissue, the liver, and there your sugar is then used as energy to do the activities of the day, right? And so if you're diabetic, particularly if you're type 1 diabetic, your body, your pancreas, which produces insulin, doesn't produce insulin, and your body then can't respond appropriately to a glucose load, a sugar load in your blood. Okay, so that's type 1 diabetes. It leads to what's called hyperglycemia, high blood sugar, and that leads to the pro-inflammatory state, the perpetuation of illness and risk for a myriad of other chronic illness and disease. All right, and that's compared to type 2 diabetes, in which you basically your body doesn't respond to insulin as it should, and as a result, then you have hyperglycemia. Okay, so in this instance, we're focusing in on how COVID can cause type 1 diabetes based upon literature that we'll present here today. All right. And so when we're talking about the consequences of COVID-19 on the organ that produces insulin and can lead to diabetes, we're talking about the impact to the pancreas. All right. And when we're talking about this particular study, actually, we'll back up. So we'll get back to this study in a second here. But we want to jump to, in terms of the impact to the pancreas, a study that looked at a multi-center regional data out of London. All right, and this study was published in the Diabetes Care publication, and it was an observational study as well. And it looked at, when they published this back in 2020, right, the increasing incidence of children that were presenting with what's called diabetic ketoacidosis. All right, diabetic ketoacidosis is a condition in which your body is basically starved of energy, nutrients you need for energy, the glucose, right? So you're not able to process the glucose appropriately in your blood, and you start producing ketones as a result of alternative ways to derive energy. And I'm obviously truncating that whole science behind them. But in short, if you become ketoacidotic, or you produce ketones to the point where they're detectable at high levels in the blood, it can be life-threatening. And so this study looked at and observed a higher incidence in children in the UK at several centers, 4 centers involved, early in the pandemic, right? And so they were the earliest to raise the question, is there, or could there be a link between incidence of COVID and presentation of diabetes? And again, this looked at children, age 23 months to 16 years, that presented with new onset type 1 diabetes. All right. So again, very alarming. And we talked in the past about the continual unknowns in terms of impact of COVID, right? The analogy we gave before in previous presentations was analogy to polio, right? When polio was a pandemic and still an epidemic, individuals weren't necessarily concerned about dying from polio, right? They were more concerned about the poor health outcomes, being paralytic as a result of a polio infection. And so we talked early on about some of the presentations of COVID short term, and now we're getting and seeing more data on the long term consequences of COVID, diabetes risk being one of them, right? And so obviously we're talking about this because it's germane to your workforce, because we know diabetes not only affects that individual's health and wellness from a standpoint of their maintenance of health throughout their life, it impacts their performance at work. We'll touch on that a little bit here, and it impacts their productivity and the bottom line of your institution, right? And so if we are charged, as we've been talking about, shifting because of COVID from just safety into more wellness, this is a very solid body of evidence showing and undergirding that need to expand our scope continually moving forward to help protect our workforce against chronic illness as a result, not just from infection, in this case of COVID, but long-term effects from chronic illness. And so let's keep going, right? So if we look at then the data from this study, we can see and highlight that they looked at was there any biases from a standpoint of race and ethnicity or comorbidities, et cetera. But at the end of the day, it was clear cut that particularly in the sites that they looked at, it went from a case rate of 4 to 5 cases, right, in total for all 3 locations over the course of a 5-year period of new presentation of type 1 diabetic ketoacidosis in children to up to from 4 cases at all 4 sites to 2 sites in particular having 10 cases within a several month period after the onset of COVID as a pandemic, right? And so the case rate was alarming. That's why they published this data. And so we'll continue to look at what would be the cause potentially of this phenomenon. So let's dig into the pathology here a bit, okay? So put on your pathology hats here. Last time we talked about last month, the clear-cut multi-organ target of that COVID has, SARS-CoV-2, right? And that it can cause effects on the brain, the liver, et cetera. And so this is an understanding, a deeper understanding of what those causes, the source of those causes are, right? And it comes down to, at the end of the day, what we mentioned way back when, I think in the beginning of the pandemic, which was a phenomenon called the cytokine storm, right? So cytokines are chemicals in our body that help communicate a myriad of things, right? In this case, we're talking about communication of activation of the immune response. So the inflammatory cascade that's promoted by cytokines is what in particular is called interleukin-6, is probably the one most studied that has effects in this case on the pancreas itself and its ability to produce insulin as a result of direct insult from the inflammatory processes that ensue as a result of the cytokine storm, okay? There are other theories out there that suggest that the direct infection, viral infection into the cells of the pancreas may cause the deficits we see from the perspective of production of insulin by the pancreas. But it looks like most likely the inflammatory cascade, which we know affects the blood vessels, the brain, and other organs, is the likely cause of the underlying condition that leads to type 1 diabetics as a result of COVID infection, all right? And so I told you we'd come back to this study that was published just recently here in 2022. And we want to look at then, again, the theory that the approach of COVID into the cells of the pancreatic cells can be a potential mechanism. We won't go into the detail of that mechanism. I think that'll be beyond the scope of where we want to live from a pathologic or pathohistochemistry standpoint. But we want to also talk about, again, the disruptive effects that it has from an epidemiology standpoint, right? We want to look broadly. We want to see, is this an issue that we should be concerned about, or is this something that is minimus in its impact to the population holistically? So let's do that, all right? And so when we get into the epidemiology in terms of how impactful COVID is regarding the development of diabetes mellitus, I want to pause and talk about the clear-cut evidence that diabetics here in the U.S., right, are one of the highest and most deeply impacted individuals from a mortality standpoint as a result of COVID, right? And we'll touch on this in this segment here of epidemiology, but we're not going to, again, focus a whole lot on those numbers and the impact, because we want to stick to how do we, or should we continue to protect our population from COVID risk in the workplace because of potential long-term effects that will evidently carry forward in perpetuity. Once you develop type 1 diabetes, it's likely not to be transient and permanent in nature. And obviously, we can then look at one of the other health outcomes that that individual would experience, right? And so when we talk about then the post-acute phase diabetic condition and studies that have looked at it in terms of its overall impact, this article was published recently here in the Lancet, okay? The Lancet Diabetes and Endocrinology publication. And just March of 2022 is when it was published. And it looked at and tried to quantify then the risk of diabetes, of developing diabetes after a COVID infection. And they looked at it from several perspectives. They looked at it from the individual that was non-hospitalized, the individual that was hospitalized, and then another cohort that was hospitalized and in the ICU, right? And so when we started to look at the evidence and the results that this study published, we can see that the risk scores, right, for developing on an individual level, right, and then in aggregate, the risk scores for developing COVID-19 it was up to a 1.4, okay? In short, anytime the risk score is higher than 1, you have increased risk of a potential health outcome, right? And this study did have a control, actually 2 control groups, and the data came from the VA, right? So the VA had both a contemporary group of controlled individuals, meaning that the individuals that developed COVID-19 and they then looked at, did they develop diabetes as a result, were in contemporaneous, in a temporal standpoint, to the one group of the control population, okay? And then they also looked at historic population that preceded the pandemic in terms of a control group to compare to the experimental group, in this case, the cohort, so that they could have further data to understand, did the pandemic presence itself present any biases in terms of treatment or things of that nature in the environment. And so when we look at then both the health risk for developing diabetes, in this case being 1.4, and then looking at excess burden being 13.46, and that's per 1,000 individuals over a 12-month period. We also then can look at, per this study, what is the incidence of having anti-hyperglycemic use, right? And basically, an anti-hyperglycemic medication is designed to keep the glucose or the sugar out of the blood at high levels that can cause damage and other pro-inflammatory responses, right? And so like metformin would be a great example of that, right? And so individuals who required anti-hyperglycemic use also were included in this study so that it would be a more of a holistic picture in terms of COVID effect on pancreatic function, all right? And so let's look at the data in a different light here. We can see the different categories, again, or cohorts, the diabetics, the anti-hyperglycemic use, and then they combine these two into a composite to look at overall risk and hazard ratio, which is risk, and then also the burden of illness. And so what we see and what we found, again, when we look at burden per 1,000 individuals, non-hospitalized individuals had increased risk for developing COVID-19, or excuse me, for developing diabetes, right, type 1, compared to the control, 42.7 versus 34.4. All right. If we look at hospitalized, even higher, 91.35, and then intensive care increased almost, in this case, almost fourfold when we're talking about 123.4, right? And so it's clear cut, right? And you know, the early assumption, perhaps in your minds, when I presented this was, sure, this is probably a population that got dramatically ill as a result of the COVID-19 infection and then developed diabetes, right? And if you look at this evidence published in the Lancet, that's not the case. Even if you were non-hospitalized without a severe case of COVID-19, you still had increased risk for developing diabetes. All right. And then if we combine then both the diabetic risk and antihypertensive, antihyperglycemic use risk, we can see where that stands in terms of increased risk after a COVID-19 infection for both these potential outcomes combined, right? And so again, that point paints the picture very clearly that there is substantial risk for our workforce population that experience COVID-19 infections to then develop diabetes. And all obviously we want to talk about as we get into the second half of this presentation, what impact that would have from a workforce productivity standpoint, obviously from a workforce spend in terms of the institutions, particularly that are self-insured, okay? So let's pause. Let's do some epi that we typically want to look at, because I know there'll be questions around kind of where we are today with COVID, and we want to answer some questions prospectively, right? So let's look at the numbers as it stands today, US versus some of the common across the pond nations that we've been tracking over time. You can see clearly that Germany is at its peak. Let's focus real quick on the US though. The US numbers are still flat, right? They're not necessarily dipping at this point. They're flat. They're not as low as we were June of last year, okay? So we're still above that threshold. But we'll talk about something that's very telling and concerning in a second. But if we look at Germany, Germany has surpassed their their initial Omicron peak 2 weeks ago, or not 2 weeks ago, excuse me, a month and a half ago, right? And so they're experiencing tremendous burden. Italy, so too, experienced tremendous burden, as you all have seen. The UK is up there, but have been declining. And so the question still remains kind of where we're at from a BA2 standpoint, BA2 being the subvariant we talked about last month or the month prior to. For 2 months we've been talking about it. And we know now BA2 is the dominant 78% or more cases here in the US, and we are not seeing the spikes that we've seen in the past. Now, there's some concerns around taking that at face value, right? If we look at the underreporting that CDC estimates, we're underreporting cases more than half, right? And that's likely because of the rapid tests that are being done at home not being reported. We've mentioned this before. If we look at seropositivity data, again, same picture, that we're underreporting by at least half, if not more than half. And if we look at our wastewater positivity rate, that's increasing as well, right? And so it kind of brings to the forefront, right? What should we be paying attention to, right? One may say and suggest the CDC data on hospitalizations and severity there. And so we'll talk about that, right? Let's talk about it in a different way though. Hospitalizations we can track on CDC, but let's look at something no one is really tracking and paying attention to that is very concerning. The case fatality rate, moving average 7-day case fatality rate, US versus other nations, right? And if you can, let's zero in on the US and let's see where we stand. Case fatality rate of almost 1.8, okay? That's compared to, right, the UK, which is almost a 1/10 of that, right? Germany, which is almost 1/10 of that, and Canada, which is at 0.5%, right? So it begs the question, what's going on in the US that we have a almost 10x increase in case fatality rate from COVID as it stands today, right, versus other nations. And I want to make the point of this particular fact because it bears in mind, should we still be concerned about preventing transmissions here in the US? Clearly, the answer is yes. If we are talking about loss of life as a primary motivator to help prevent transmission, right? So again, one way to look at how bad things are hospitalizations, as you know, we can see from the CDC. But I think we should also be including are people dying from COVID at a rate that's substantially beyond that of our neighbors. And that gives us a good sense of, even with their tremendous burden of illness, again, their burden of illness is an order of magnitude beyond ours, right? In the UK, Germany, and the like. But our people are dying at higher rates. That's concerning, right? And so that's motivation to continue to protect our workforce, if none other. So when we're talking about then the overall effects of COVID on diabetes, right? We know that we have been and we continue to be, as this New York Times article points out, in store for a public health train wreck, right? And that's not accounting for, that's COVID effect on diabetics, right? And we know the evidence there in terms of risk factors, but diabetics are making up at this point 40% of deaths from COVID here in the US, right? So now tack on a new population of type 1 diabetics as a result of previous COVID infection. And now we're just stacking up and adding to the susceptible population for death from now variants that may pop up and affect us as a nation, right? And so it's a compound effect that, again, we need to be cognizant of and we need to be discussing, because, again, every effort should be taken at this point to try to minimize risk for transmission, both at home and at work, right? And it, again, is undergirding kind of an update of where we're at. And if that's not enough, we'll keep going with a little bit more in the stats in terms of looking at our current vaccination state, right? Vaccinations right now are at their lowest that they've been in months, right? 65% of the population fully vaccinated. I point out vaccination as a means to, again, protect oneself from poor outcomes, severity, hospitalization, and death. Still efficacious for that purpose, right? But again, we're not preventing infections with the vaccinations, but we're trying to decrease the impact in terms of loss of life and severity and poor outcomes. We do know also that vaccinations can decrease sequelae from COVID-19, i.e., if part of the pathogenesis of diabetic 1 development after COVID is direct infection and viral load of the pancreatic cells, vaccinations, we know, decrease the viral load and decrease the risk of poor outcomes, severity, and sequelae as a result. We've seen long COVID risk go down as a vaccinated population has risen, right? And so we want to suggest, again, that still should be something that is vocalized in regards to a means to protect the workforce and protect the population in general. So the question, the last question around the epi is, are we at epidemic levels, right? Can we declare that we are now going to experience COVID like we experienced the flu? Let's answer that. CDC data helps us do that, right? And we do it by looking at what is our seasonal baseline and epidemic threshold published by the CDC over the years, fast forwarding up to today. We can look at in this chart then a figure that we've tracked before, which is PIC, pneumonia, influenza, and COVID-19 mortality, all right? And if we look at the chart here of the PIC deaths down at the bottom there, coded from influenza at the bottom in the dark blue, and then in the light blue from COVID deaths, you can see that we are still far above the epidemic threshold for COVID versus the flu, right? And so if we are to accept this as a new norm, surely we're in for, as we pointed out, one heck of a train ride, right? But it makes sense and only logical that one would not consider COVID-19 to be endemic until we start to near levels that we have with influenza from a loss of life mortality standpoint, right? And so I present this so that you can articulate this back to the workforce and educate them, right, as why we still want to have some precautions in place in regards to protecting oneself in the workforce. Surely we've seen also anecdotally in those corporations that are looking to bring workers back to the workforce, it is prudent to have some protection still in place as a means to promote a return from home process, right? And so let's jump into the workforce strategies here and talk a little bit more about the impact of diabetes again. So impact to the workforce, to your enterprise. We'll get into a little of the cost here, and I promise you we'll stop early so we can still have 15, 20 minutes to answer questions. So when we're looking at data from CDC, 2020 data from CDC and updated data from CDC in regards to the burden of diabetes in the US, this helps us frame then what the impact to our workforce might be, right? So we have a total of 37.3 million Americans that have diabetes, right? That's 11.3% of the population. 28 million of those are diagnosed. Undiagnosed, 8.5 million, right? And that does make a difference in terms of calculating cost here. That we understand the cost to the diagnosed individuals. And then if we look at pre-diabetes, man, we're looking at a huge population. Over a third, 38% of the US population have pre-diabetes 18 or older, right? And we know pre-diabetes meaning that you still have blood glucose levels beyond normal. And we know that there's still health outcomes that would result from a pre-diabetic state. And now we start to look at, okay, the cost data associated with diabetes. So $1 out of every $4 in the healthcare cost here in the US, again, according to CDC, is spent on diabetes, $237 billion every year, right? Medical costs and those are direct medical costs. If we look at the indirect costs, which we've talked about numerous times in this presentation, right? The indirect costs, lost productivity, $90 billion, okay? So again, diabetes, we know, affects the bottom line and the health and wellness, obviously, of our workforce. And it's something we should still be cognizant of from the relativity of COVID impact, because that exacerbates these numbers, as we just pointed out, right? And so when we talk about the overall lifetime medical costs for an individual with diabetes, right, 48 to 64% lifetime medical costs of a person with diabetes are from complications, right? And so again, that points that if we can identify and do something to help prevent a diabetic condition, then we're going to prevent those costs over the lifetime of that individual. And if we look at then numbers that are identifying the individual's cost, it's $16,000, $16,752 a year is what we spend on an individual that's diagnosed with diabetes. 9,600 of that those dollars are for and attributed to diabetic care directly, right? And again, I'm speaking to not just the self-insured that are doling out the dollars for management of these chronic disease amongst the workforce, but also we're paying higher premiums as a result of this for the fully insured employees out there as well, right? So 2.3 times higher expenditure is what is expected from an individual who is diabetic versus an individual who is not diabetic, right? And we know the impacts to the workforce in terms of increased absenteeism, $3.3 billion a year spent as a result of indirect costs from diabetes. Reduced productivity, again, 26.9 billion, and so on, right? I mean, we have individuals that are in the workforce that have a reduced productivity at 2.3 billion of a cost, and those who will leave the workforce as a result at 37.5 billion. So at the end of the day, we know there's a lot of waste in our system in regards to lost productivity that is expended annually for a condition that may be prevented if we have the proper tools in place to help do so, right? Again, shifting from safety to wellness, but again, wrapping our minds around our COVID protective strategies can impact the incidence of diabetes amongst our workforce, right, directly. So imagine now, again, and you can reduce this to your own local cost, but for every case of COVID that you prevent, right, in terms of transmission in the workplace, right, you're saving dollars in a multiple of just that COVID case itself. We talked early on about the direct cost and hospitalization costs of COVID cases, right? It was around $20,000 annually for COVID cases that were severe, right? And need to be hospitalized at a minimum. It went as high as, I believe, $70,000 on average. And so those direct costs from COVID care are now amplified if that individual develops, obviously, diabetes as a result of the COVID. And we saw that out of 1,000 individuals that contract COVID, right, about 80 of them on average have a risk of developing type 1 diabetes as a result of their COVID infection alone, right? So again, those are substantial numbers, and again, undergirds why we should still have a strategy to help protect the workforce from COVID infections, because at the end of the day, we may save a lot of time, effort, productivity, and costs by doing so, right? And we want to comment on one additional thing. This is kind of a bonus. I know there's been questions out there around the vaccine that's specific for Omicron. There's data showing now that that specific Omicron vaccine does not work substantially better than the early vaccine against Omicron, our original vaccine. So I wanted to answer that just in case there were questions out there. And we know that boosters are now recommended for at-risk populations and immunosuppressed for age demographics. And we're expecting that in the fall, everyone will be recommended to get a booster. We'll talk about the pros and cons there. We know that 5 and under still can't get boosters here in the US. In terms of the FDA approval, but we can answer questions in those specifics. So at the end of the day, yes, keep things in place that help protect the workers, if at all possible, right? So that your process of protection is no different than what we have in place, that we've had in place in the past. Just to reiterate, we're talking about screening, health screening, early testing, identification. We're talking about the fitness for duty and the long-term disability prevention strategies, as well as identification. We went through that last week in terms of long COVID and how to help address that. And then we want to promote vaccination still in those populations that are still willing to do the boosting, et cetera, because we know it will save lives as well as decrease overall long-term burden from a health cost standpoint, a worker health experience standpoint. So keeping with my promise, we are going to stop it there. We have a little more than 20 minutes to answer questions. So Karen, let's go ahead and jump into it.
Thank you, Dr. Harris. We'll take a couple of the questions related to diabetes and then more general after that. So the first question is, if you're vaccinated, does that decrease the risk of getting type 1 diabetes if you do get a breakthrough infection?
So in theory, yes. But it goes back to the pathogenesis of the diabetes, a direct insult from the viral load into the cells of the pancreas, or the inflammatory response as a result of the infection. So yes, in theory, it should decrease your risk of getting and developing diabetes, as we see with other sequelae and long COVID. However, I have not seen any peer-reviewed studies that have looked specifically at a decreased risk as a result of vaccination for developing post-COVID type 1 diabetes. Anecdotally, unfortunately, I do know an individual that was fully vaccinated and boosted and developed diabetes after they had an infection of COVID-19, and this was just recently last month. So it can still happen. However, the risk should be lower, and this was an individual that had no pre-existing risk factors otherwise.
Okay. Do you happen to know what percentage of the population in Germany has diabetes type 1 or 2 compared to the US population? You showed the US data.
I do not off the top of my head here, but that's something that we can answer and get back over to you here shortly, for sure.
Yeah, I figured we could look it up, but I don't know the answer to that specific country. Could you elaborate a little bit further on the impacts of diabetes in the workplace, the costs associated, like days of absence compared to an employee who doesn't have diabetes?
Sure. So in terms of specifics around what is the number of days from an absenteeism standpoint of a person with diabetes versus a person with without diabetes. I don't have the specific percentages on those of that comparison. We did present, however, the cost burden as a result from absenteeism as a specific result of diabetes in the workforce, right? And so that is the $3.3 billion spent on absenteeism as a result, sole result of diabetes here in the US. So that does give you an idea, relatively speaking, in terms of how much is spent and what the cost is for our individuals with diabetes in the workforce with absenteeism. And it looks like around 7 million people in Germany are diabetic, according to their the health ministry.
Okay, 7 million. Okay. So can you repeat the risk of type 1 diabetes in COVID cases again, either the odds or a percentage
Sure, let's go
based
back
on
to
the
that.
studies?
Yeah. So if we look at per 1,000 individuals over a 12-month period with a 95% confidence interval, right? The control group in this case, in this study that was published in the Lancet, and the group were out of the VA, the Veterans Hospital, 34 out of 1,000, right, developed diabetes in the control group. If we look at then those who had, and these are individuals without exposure or documented COVID-19 infections, those individuals from the experimental cohort that were matched to the control had 42 individuals that out of 1,000 that developed COVID-19. If they were hospitalized, it went up to 91 individuals, and then intensive care, 123 out of 1,000 over that 12-month period developed diabetes, right? And so that gives you an idea of the impact that COVID has on your risk there.
Okay. Is there an A1C that makes diabetics more at risk for developing COVID, or is it just having diabetes in general?
So yeah, surely if you are poorly controlled, right, you have more susceptibility to poor outcomes because of the long-term effects of hyperglycemia on not just the vasculature, but multiple organs. And particularly in the inflammatory cascade that can be increased as a result of having poorly controlled diabetes, which is high levels of hyperglycemia and higher A1Cs. So it's a continuum. There's not a clear cut, below this number, your risk is 0 or your risk is low. Surely, if we use just best practice in regards to good control of diabetes and A1C, right? Those standards are still in place and decrease your risk for poor health outcomes, but it doesn't reduce it to 0, right? So merely having and being diabetic does increase your risk baseline.
Okay. So if someone is diabetic and they get COVID and they're hospitalized, are they likely to see more challenges with controlling their blood sugar during their recovery?
Yes, that has been documented that, and that's with common inflammatory illnesses and infections as well, right? If diabetics who particularly are hospitalized and experience significant illness and they're hospitalized for it, may have periods after their discharge of having more difficulty controlling their blood glucose levels. And so that data has been well documented, and individuals on discharge are actually counseled to watch closely their blood glucose levels who are diabetic because of that phenomenon. So too would be obviously someone who presents with new onset diabetes, in particular the children that we talked about that develop DKA, diabetic ketoacidosis, would have significant impact to controlling their A1C, but their blood glucose levels after discharge from the hospital.
Okay. What are the ways to fight type 1 diabetes due to COVID in the workforce? And what would you recommend for as far as health choices for type 2 diabetes? So this question is really asking about what can we do to educate the workforce to help them better manage their diabetes if they're type 2, and if they're type 1, what approach would you recommend?
Sure. So the classic tenets of diabetic control for type 2 diabetics that have insulin resistance, it's called, where they make insulin, their body just doesn't respond to insulin in terms of the receptors. The classic tenets of good control there, diet, exercise, right, good monitoring of the A1C as well as daily glucose hyperglycemic states, right? And those haven't changed, and COVID won't necessarily impact those recommendations, right? But for the type 1 diabetics, unfortunately, the only course to help prevent the risk of developing type 1 diabetics as a result of COVID is to prevent the COVID to begin with, right? Because we have not uncovered yet a clear-cut pattern or risk factor for developing type 1 diabetes as a result of COVID infections. Now, some of the studies have looked to that, right, to see if there were, are Black non-Hispanics at higher risk or white non-Hispanics at higher risk. And we need more data to support and point towards any patterns there. But it's clear that preventing the infection of COVID-19 will obviously prevent the risk of developing type 1 diabetes. After you develop type 1 diabetes, unfortunately, at this point, it looks like it's not going to be transient. It may be permanent in nature. Time will tell. And there, again, good management techniques and counseling would be standard.
Yeah, okay. This is an interesting question. Referring to long COVID in general, not just diabetes. Are there different long-term effects based on the variant that you're exposed to or which you become infected by? Delta, Omicron, et cetera.
Sure. So at first we didn't know, right? We had Alpha, then Delta sprung up, and with Omicron. And so what we're seeing now is that long COVID is not precipitated more by one particular variant than the other. Now we do, and we have seen in terms of the variants, difference in targets and organ targets, not between SARS-CoV-2, but between SARS-CoV-2 and SARS-CoV-1. We're talking 2003 SARS, right? So if we look at MERS, if we look at SARS-CoV-1 and then now SARS-CoV-2, they did have different end organ targets based upon the receptors that each of those, not variants, but different strains of the coronavirus were. But again, when we're looking at the different variants, they all seem to have and carry the risk of long COVID and the ill effects, long sequelae, regardless of the variant thus far.
Okay. Jumping to a different kind of question, we continue to struggle with when to phase out masks and daily screening, since case rates are lower but not yet fully under control. What are the key considerations to phase out these two precautions if CDC levels are stuck in low even as case rates go up?
Sure. So again, what we presented today should be a part of your consideration, right? Case rates at this point have not reached their minimus of last summer, right? And so when we're talking about, are you all still seeing my screen? I want to make sure.
Yeah. It's good.
Okay, perfect. So, again, I think at this point in time, unfortunately, the COVID fatigue has set into a, paramount level that we're, feeling like we want to be done with COVID, right? But if we look at the numbers, we haven't hit levels as low as we did even last summer before we spiked again. And there's no evidence to suggest that we are out of the woods in terms of experience.
Oh, we're losing your signal.
Let's call it the political will or the pressure of the populace is that something, then I would prioritize then we do away with first. That's the easiest to restart, right? And so those who are doing the habitual, daily check-ins and daily screens at the front door, or whether you have a guard doing it or nurses doing it, or you're doing it digitally, those habits are harder to start back up once they're gone. If you're talking about mask wearing, again, I think we've already gone through a couple cycles of, relaxing the mask, putting the mask back on outside of the airline industry. And so perhaps when we're talking about prioritization, mask would be first in terms of decreasing those in the workplace, right? And we've seen that play out in the schools and collegiates as well. And then when we're talking about testing, I think testing is going to be with us for some time longer, right? Because we know early detection, early testing is a way to decrease workplace transmission. Again, going back to the data from Columbia University from 2021, we know that the more you are able to test a population, the more likely you are to prevent workplace transmissions. And so that would perhaps be one of the last things to go as we talk about long-term, doing away with all precautions and treating COVID like a common cold.
Okay, we have quite a few questions about the BA2 variant, which all basically follow the same theme of how serious do we think it could become. But let me ask this one question, kind of has a different angle. With the BA2 variant now in greater than 70% of the population in the US, and its R naught is around 14, almost as contagious as the measles, are we seeing evidence of some level of herd immunity as new case rates in the US are continuing to improve in most states?
So yes and no, right? So the theory is this right now, clinically and amongst epidemiologists. Yes, we have some resistance in the population due to the overwhelming number of cases we've had from BA1, right? But if you look at when that immunity should start to wane, we're going to hit that mark roughly next week, 90 days after our peak from January 15th. January 15th was the peak. And so we're starting to hit that 90-day mark in the population in which, in theory, we may start to see now more cases present and numbers start to go back up. The second piece of it is we are woefully underestimating our burden of illness, right? If we look at the data on the number of tests that are conducted in the US at this point in time versus our peak, right? We're at a dismal rate of where we used to be, right? Right now in the US, on a 7-day rolling average, our testing is about 2.5 per 1,000 people, right? If we looked at our peak, it still was dismal, but it was higher. It was at 7.6. Right, so we were 3 times higher when we were at our highest peak of testing. Now compare that to the United Kingdom, right? They are testing well over 28 to 29 tests. I think it's like 27.3 last time I checked. 27.3 tests per 1,000 individuals, right? Compared to our 2.5. So that should give you some indication. As we talked about back in 2020 when we were doing these lectures, we would show you the rate of testing per nation and the rate of positivity and how just not testing will equal lower rates of detection. And now you amplify that woeful underestimation because we're not testing with rapid tests that are not being reported. And we are in a perfect soup for not having a clue of what our current burden actually is, right? And so perhaps, I'm not being too jocular with this, in their wisdom, the CDC said, you know what, let's just throw out the incidence data and look at hospitalization data. And that will be enough in terms of risk. I would, in all other aspects, agree unless you start to look at what we presented earlier, which is the case fatality rate, right? I mean, our case fatality rate is higher than every other. We're bested by India, and that's about it in terms of developed high-tech nations, right? So it begs the question: what should we be paying attention to? The epi data should still be relevant to some meaningful extent when we're considering, where we stand. And okay, and specific to the BA2 virus, though, I mean, yes, we know the BA2 virus did not have, even though highly transmissible, right, did not have the same severity as Delta did, right? And then we had, as of less than 30 days ago, the presence of, you probably heard it, Deltacron, right? Which is a variant that is a blend of Delta and Omicron, right? So you have the two at the point of where BA was still around while Delta was around. You had the presence of both in the population, and that leads to mutations that can happen in one or more individuals in which the viruses replicate together and cause a new strain. They called it Deltacron. Now we have, as of this week, identified 600 cases in the UK of a strain called XE, right? And that's a blended version of BA1 and BA2 subtypes of Omicron. And we found that it may be 10 times more transmissible than even BA2, right? And so we'll see how it's playing out in the UK. It may be part of the cause in Germany as well. We yet to see, because now the testing for XE is starting to increase. We're not testing for it yet in the US. I'm sure we will in the next coming days or weeks. But again, it points and begs the question, will we see another spike as our immunity from BA1 starts to wane basically next week as we have the emergence of these new variants?
Wow, I hadn't heard about XE. I'll have to look that up. So this is a question about another protective measure. Do you have any predictions on when contact tracing will no longer be required?
Sure. So, that question is probably more tied to an OSHA regulatory standpoint, right? And so while OSHA still considers workplace transmissions as a increased risk for the workforce of the population, then contact tracing may still be amongst us, with us, right? But should that regulatory lens change, and now it's considered a general epidemic type of infection and no increased risk from the workplace, then we may see relaxing of contact tracing in that regard. But again, that's probably more tied less to clinically versus OSHA regulatory.
Okay, you mentioned flu vaccines in connection with the fall and COVID vaccines in the fall. Is there any chance we're going to see a flu vaccine that combines both?
I believe the answer is probably yes. We knew last season that there were 3 pharmaceuticals looking at a combined COVID flu vaccine. We didn't see that take off, right, particularly, but this go around with the new season, we may likely see that, because the need to get both at the same time and 2 jabs is something that's less pleasing, if we're looking at people who will sign up for both.
Right, I think I got mine combined last season. 2 shots in one day, not the most fun.
Yeah, 2 shots in one day versus 1 shot with both combined in the same.
Yeah, but at least you get it over with. Okay,
Indeed.
So we're running out of time, and there's just one clarification question. The person says, this has been a little over my head. And so the bottom line is they want to know, what is the actual risk of getting diabetes from COVID?
Sure. So
she says, if someone did not have diabetes, what is the percentage that may become diabetic? What's the composite outcome?
Sure, that's this number here, right? Let me grab it real quick. This number that we presented here, right? If you are not diabetic, right, and you contract COVID-19, it does depend if you're hospitalized versus not hospitalized versus in the intensive care unit. Your risk increases at each level, right? But let's take the most extreme. If you are hospitalized and in the intensive care unit, out of every 1,000 people, right, roughly 148 of them will develop diabetes as a result of their COVID infection. So that gives you the quantification of risk. And when you're talking to the workforce, the easiest answer to respond is you actually have higher risk of developing diabetes from COVID. As a result of COVID infection, right? And just keep it black and white, right? Because people yet don't understand that this is even a risk to begin with, let alone quantifying it for them, right? Just as the risk of long COVID, is a third of the individuals. So they may not understand, that the sequelae of long COVID may be brain fog or, persistent cough and fatigue and exertional fatigue, right? But just keeping it simple as your risk of having long COVID is, a third. So that I think keeping it, kind of black and white around diabetes may be very impactful in terms of protect yourself, because you want to, just like we said with polio, right? You may not be concerned about dying from COVID, but certainly you should develop some concern around what other things may happen. Now we know diabetes is one of those.
Okay, squeezing in one last question, and you may want to address it next time. What's the latest research showing on transmission when comparing vaccinated to unvaccinated individuals?
That's a great question, and we need more data around that. There's some evidence that it is lower if you're vaccinated because of lower viral counts. But yes, that's something we'll need to gather more data around to see where we're at. I haven't looked at that in particular in depth in the last couple weeks. So we shall present that next month for sure.
Okay, so thank you all for joining us. Thanks again to Dr. Harris. As always, we really appreciate your expertise. And we'll see you back here on May 4th. And again, to remind you, look out for our invitation to our ergonomics and total worker health webinar on April 20th. Thanks again for joining us. Take care, be safe.
Thanks all. As always, stay safe and God bless.